Thank you very much, Professor Cox, for that very elegant presentation from which I've certainly learnt a lot. We now have scope for discussion. And I think what I'd like to do is to ask Dr. Connolly, Professor Cox, and Dr. Cowan to come up here. I'll move you. So, stay there. I'm sorry to take the podium then, but what I'd like to do is to invite questions from the floor in the first instance. Professor Lemaire, thank you.
Well, I will start off. This for Dr. Cox. I know what your answer will be, of course, but if you had to leave out one lesion out of your maze procedure, and I don't say I won't let out any lesion, but if you have to let out one lesion, what line? Which line would that be?
The one to the right atrial appendage. I know you wanted me to say the mitral line, right?
No, not at all. Not at all. No.
Well, if you'll
you
notice,
will never say that.
Actually, I will. If you, I'm writing an editorial on this now. If you notice that hybrid procedure I put up there, I put it quickly. I'm going to talk about that late this afternoon. There is no mitral line in that lesion, in that drawing. And the reason is that it's basically impossible to put it in with a thoracoscope, I think, in most people's hands. If you do an initial surgical procedure or you do a joint surgical procedure. I think the problem, it's not easy to do with the catheters either. But I think that one of the things that you can do as a surgeon that can really help the catheter ablator a lot is while you're on the epicardial surface and going around the pulmonary veins and so on, if you'll put a radiopaque vascular clip at the bottom of the left inferior pulmonary vein and then another one at the coronary sinus, so that when the catheter person when the EP is doing his part of the procedure, if you need that mitral line and the coronary sinus lesion, you know exactly where you put it. I mean, it's not any longer than putting the right atrial flutter lesion in, which they're very good at. We learned that years ago because we realized that if we had a recurrence, it was always at that area in the coronary sinus usually. And so I always put vascular clips along the incision so that when we came back, later on, if they had atypical left atrial flutter or perimitral flutter, Bruce Lindsay could find it very well with a catheter, and it took him 2 minutes to fix it. I think that, I've always insisted on that procedure because there's a difference in doing a definitive surgical procedure if you're trying to cure the patient with a surgical procedure and doing a surgical procedure as the first step or a combined step in a hybrid procedure. Those are two different procedures. We always insisted on the mitral line coronary sinus lesion in 100% of patients because we knew if we didn't do it, we were going to have a 15 to 20% failure rate. If you stage your surgical procedure first, catheter procedure later, 80% of those people, 85% of those people will not ever need a mitral line because they're not going to develop atypical left atrial flutter. So you're talking about coming back later with the catheter and having to put that line in maybe 15 or 20% of patients. So the reasoning and rationale of the lesions that you should put on, I think, as the initial step of a hybrid procedure, that reasoning and rationale is different than if you're doing a definitive surgical procedure and there's not going to be a follow-up catheter ablation.
I was struck by your comments about the plethora of lesion sets that are described now. Am I allowed to put Sam on the spot and say, in your talk next time round, in the next session, are you going to be discussing anything from Mays and whether there are any similar observations about the variety of lesion sets that surgeons use as part of the AMAZE trial? No. Okay. Any observations then?
So they're all lumped together.
There are many lesions and very little justification for what a lot of people are doing. So I agree with you.
Yeah, it's the problem that was in the FAST trial and several other trials and the trials that were referenced by Dr. Cowan and his nice recommendations. The problem is that it's like in the States, if somebody wants a brown fizzy cola, we ask for a Coke. And we may get a Pepsi Light, you know, but it's not the same drink, but it's called a Coke. And I think, unfortunately, the term maze has become generic for anything that's done to the atrium in an interventional manner, and that's just not, that's not okay. I mean, there's a specific way to do that. There's a specific concept. There have been 4 or 5 different mazes developed, and they all work fine, but they all adhere to the concept of ablating the macro reentry and leaving the atrium so that it's in a sinus rhythm. Anything short of that, if you don't put all those lesions in, you're setting up you're making it arrhythmogenic. You know, you're going to make it more arrhythmogenic. So when you see, I mean, the first thing I do when I see comparisons in the literature, and I see every one that's ever been written, I suppose, the first thing I look at is what's the lesion pattern. You know, the first thing I look at recommendations. What are the recommendations? It's not okay to recommend lesions confined to the left atrium for the treatment of non-paroxysmal atrial fibrillation. That is not okay, because it won't work. We know that.
Important, fantastic message. Thank you.
Any other questions from, yes?
Hello, Manuel Castella from Barcelona, Spain. I was one of the co-authors of the FAST study that Dr. Cowan presented in the last study that you presented. And I have a question. Honestly, I think there's an imbalance between the results published in the literature about catheter studies and then the recommendations on the guidelines. Because, for example, in the FAST study, in persistent atrial fibrillation, the results with catheter ablation was a 36% success rate at 1 year. And also, when Dr. Cox has shown the results by Dr. Cook or Dr. Heisager, there's between 45% success rate with more than 1 ablation at 5 years. But still the recommendations are very positive on these therapies. And for example, in the 2012 guidelines, they say that for paroxysmal AFib, it can be the first line of therapy before medication in selective patients. And I would like to ask the panel, what do you think about this? For me, at least, an imbalance between recommendations and results. Thank you.
Shall I come in first? I mean, the first thing to say is we have not said that ablation is first-line therapy. Explicitly, we have said the opposite, that it should only be used for symptomatic patients where drugs have failed to control the symptoms. Okay, that's the first point. So I think I agree with you there. The second aspect, I think we're agreeing again, actually, because we are making a consensus judgment on the evidence, but largely the Bosma paper, that the results for persistent atrial fibrillation for catheter ablation are not so good, and therefore we have ranked catheter and surgical ablation equally. Now, I know what you're saying. The paper showed surgery was better than catheter ablation, but that is for people who have failed ablation previously, and that's why we have put in a consider both. We're saying surgical ablation has to be considered alongside catheter ablation for that group. So what would you have liked us to have said?
Well, one of the things is what Dr. Lamer was saying, that I was going to be my question to you first, is that after failure on catheter ablation, probably surgery could be an option. And I never see that in any guidelines, even in paroxysmal. We agree that maybe catheter ablation can be the best option as first step. But we see many patients with 2 or 3 and 4 ablations. And they go very well with surgery. And that was shown clearly on the FAST study.
Do you think, though, that it is an indictment of surgical ablation that we do not have a straight RCT against control showing efficacy?
I'm sorry, I didn't understand very well.
There are no prospective randomized trials.
That's correct.
Yeah.
Well, there's only one,
I would
yes.
like to just speak to that, and I know it's not going to be very popular, but I'm going to say it anyhow. I think that we have become addicted to prospective randomized trials to such an extent that it's actually hampering our ability to get to the truth. I really do. We somehow just sort of accept that no evidence is good unless it's in a prospective randomized trial. Another way of saying that is that evidence that have been developed let's say evidence that has been used to construct a certain treatment therapy, insulin for diabetes was used for 50 years before a prospective randomized trial came out, because it was based on an enormous amount of science, well thought through, well tested in the experimental and clinical laboratory, and it worked. And I maintain that the same is true for a lot of other conditions, one of which is atrial fibrillation. I mean, because it's not reasonable, I think, to think we're ever going to have a prospective randomized trial between medical therapy and a surgical procedure like the maze or some variant. But we're never going to, as I alluded to, we will never have a prospective randomized trial about whether airplanes fly better with or without wings. We know from well-based science that an airplane will not fly if it doesn't have wings for lift. And the fact that there's no prospective randomized trial to show that is meaningless to me. And I think it's true. It's true not just with cardiology and surgery, and not just in Europe or the U.S. We have just become addicted in this specialty to prospective randomized trials, and to completely disregard every study that's ever been done that has good basic science in it. It just doesn't seem right. And I know that's classified as, level B or C or 3 or whatever, but you mentioned, and I certainly respect your choice to do so, but you mentioned that unless you had a prospective randomized trial, it was considered to be no evidence, and therefore nothing is included in these nice recommendations other than prospective randomized trial. And I can't believe we've gotten that far, because I think we're missing the benefit of a lot of science that is sound science, just like the science that went behind the Wright brothers flying that first airplane.
As a clinician, I agree with you, but I guess we work in an era where we're competing with other specialties for funding, and the guideline group that I was chairing this committee for, they're not just looking at atrial fibrillation or AF ablation. Next week they'll be looking at cirrhosis or head injury or something completely different. And so they have a methodology that they have got to use across the full spectrum of medicine, and that promotes the RCT as being the prime level of evidence. Now, yes, I do have a problem where you go after that, and that is the issue.
Well, we have exactly the same problem. I just met with the FDA last week, a week ago today, I guess, and it's the same problem. Unless we're going to them with an idea for a trial, and unless it is a prospective randomized trial, then it's very difficult to get it through the FDA, because that's where they start. And it's very frustrating. I understand that the reality of it. We're never going to have a prospective randomized trial that shows the maze procedure or anything else is better than medical therapy. You just can't get there.
Could you have it against catheter ablation?
Well, we could have it against catheter ablation, sure, but I mean, what are we going to learn that we don't know? I mean, we know what the results of surgery are. It's been used 500,000 times. We know what the results of catheter ablation are. It's been used 2 million times. And yes, we can go and get concurrent therapy, but I mean concurrent arms. But if we start, let's say Mark Lemire or Manuel Castells or Stefano Benucci decides they're going to do a prospective randomized trial between catheter ablation and surgery, that would be fine. We already know what their results are. They're absolutely superb, and they're long-term, and they're followed closely, and so on. And we know the best people in the world what their results are for catheter ablation. Now, if Stefano does one in San Rafael, and he's going to do the surgery, he's got to get some cardiologist, Paponi's gone, whoever's there now, is going to be doing the electrophysiology. Are we going to expect him to do any better catheter ablations than Hasegawa or Cook? I don't think so. And they were published 2 years ago and last year. So, yes, we can do that, but the fact that the data are specifically concurrent data does not make them any more accurate than what we already know.
Jimmy, I accept everything you're saying, but it would make it much, much easier for regulatory authorities.
I understand that, but that's because that's because the regulators have decided that's what you have to have. And so we're in a circular discussion.
Can we steer ourselves back slightly to the presentations? I was struck in Dr. Connolly's presentation by the large early mortality that seems associated with AF. And I just wanted to ask the panel really whether they think that this is a piece of evidence that suggests that we should be much more aggressive about rhythm control rather than just treating symptoms, although largely it's a primary care problem.
I think two points of that. First of all, that's quite an old study. It's from Framingham, published in 1998. It's been talked about a lot. If you actually look at the deaths in that study, they were not all strokes or heart failure. There were quite a few pneumonias and whatnot. And I think what they were looking at is patients who were picked up with atrial fibrillation in hospital versus a control group. So some of those patients were dying of other things. However, it does bring it home that if we diagnose atrial fibrillation, we do need to rapidly consider the patient's risk. Now, the biggest threat for death in atrial fibrillation is the risk of stroke, and as Campbell said, there are tools out there in primary care and secondary care for identifying the risk and prioritising anticoagulation in those patients. So I wouldn't necessarily say the priority is rhythm control. I think the priority is reducing the risk of death from stroke in those patients. There is some evidence that there may be an early mortality with warfarin, that warfarin may take a while to become fully active, that there are early deaths even during warfarinization. Maybe that's a role for the new oral anticoagulants, that if we're able to move away from warfarin and towards these new drugs, we can start the drug on day one, and we know that that patient will be anticoagulated within 6 to 12 hours.
Thank you. Did you want to?
Oddly enough, one area we have really quite good, high-quality evidence from randomized controlled trials is in this rate versus rhythm controversy and the values of an aggressive rhythm control strategy. And it really shown very clearly that there is no benefit from that, and maybe some disadvantages relating to anticoagulation. Now that it may relate to difficulties with antiarrhythmic drugs and the strategies that were used to achieve rhythm control, but at this point, I don't think that we can say that rhythm control outweighs rate control.
Thank you. Any last questions from the audience?
Sidney Gaynor from Cincinnati. I'd like to congratulate all the speakers on the information imparted. I think the talks are very interesting. Just a comment on the new anticoagulant drugs. I think there have been no randomized trial to show any superiority of the new anticoagulant drugs, such as Pradaxia, to be more efficacious in patients who are well controlled on warfarin. There is no evidence to show that if you have a patient who is controlled on warfarin, switching them to Pradaxia has any scientific or clinical benefit.
I agree with you completely. I've not gone into strategies where we've set where the guideline puts vitamin K antagonists and the NOACs alongside each other. But we have said the two exist. We have not expressed a preference for one over the other. What we have said is that if somebody has poor control on a vitamin K antagonist, that they should then be considered for the NOACs. But we have not expressed a preference for one over the other from the outset.
Can I just ask something? And concerning the pre-ablation therapy, do you say something about the whether if the patient is on a NOAC, whether he had to change to warfarin, or is there something on that? Because there are some studies telling that there could be less efficacy.
I'm sorry, we haven't gone into that at all. That's another of our gaps, that we have not been able to look at the evidence.
Is that pre-catheter ablation or pre-surgical ablation? Both. I mean, certainly for catheter ablation, we're routinely continuing warfarin and doing the procedure with INRs of between 2 and 3, sometimes higher than 3. For the NOACs, I think most people are stopping the NOAC for 24 hours or perhaps longer prior to the procedure and recommencing the drug later on the same day, so the evening after the procedure.
When you have a NOAC prior to the catheter ablation,
I think there's a dearth of very good randomized trials. There was one American multi-center study, I think Lucky Reddy was the first author about 2 years ago, showing an excess of adverse events in the NOAC group in those who were continued on a NOAC. There's another paper from the Ann Arbor group that came out last year showing if you stop drugs such as the Bigatran 24 hours before and start it again 4 to 6 hours after the procedure, that it appears to be safe. But this is all non-randomized data. As Dr. Cox says, it does influence what we do in practice.
I'm very sorry, but I do feel we have to draw this session to a close. Discussion can continue over coffee. I'm told we now have a 15-minute break for a quick refreshment, and we'll reconvene at, what would that make it? 10 to 11. I'd like to thank the speakers very much, and we look forward to hearing James Cox later on this afternoon.